Okay. Hi, everyone. I think we're going to get started. Okay. Wow. A lot of people. So good to have everyone. Thanks for coming. We are the students from Sign, and we thought for this year in preparation for the Logic midterm, we prepare like a little review session. This is going to be focused on neurology material. So we're not going to cover like ENT or psych, however much of that you did. And we're going to try to keep it within 2 hours, but it's a lot of material to go through, so no promises. We are recording the session, and we're going to make that available along with the slides right after the presentation. So if you miss anything, you're going to be able to go back to that. Okay. Just give me 1 second. I'm going to share my screen. Okay, does everyone see this?
Yes.
Perfect, thank you. All right, so let's get started. So yeah, we're going to cover a couple of topics. We're going to do cranial nerves, spinal cord, PNS, and then we're going to dive into some of the pathology, so loss of consciousness, seizures, movement disorders, strokes. So I'm going to start off with the cranial nerves. So this is going to be pretty quick. So obviously, if you haven't studied the cranial nerves yet, this might be a little much. So obviously, you could go back to these slides afterwards. Also, Dr. Moore's slides, obviously, they're amazing. I'm going to go through them in order. And I'm essentially just going to cover like the high yield, like important points for each. So just a bit of legend before I dive in. For each nerve, I'm going to talk about like its anatomy, its function, how do you examine it, and a couple of other things that you should know for the exam. And as I go through the function, I'm going to essentially color code it to make it easier to kind of organize in your head. So essentially, when it comes to function, obviously you can separate it into efferent and afferent. Efferent essentially is whatever comes out of your brain to kind of have an effect outside of the brain. So that's like motor stuff, right? So red text is going to be somatic motor. So that's the stuff that controls your skeletal muscles. So I'm just going to call that motor. Brown text is going to be for brown gold text. That's going to be for autonomic stuff. And you should note that when it comes to cranial nerves, autonomic function is always and only parasympathetic. Okay, there's no sympathetic cranial nerve function. And for the afferents, so the sensory stuff, the stuff that goes into your brain, right? Sense periphery and goes into your brain. So blue is going to be for somatosensory. So that's like your touch, proprioception, stuff like that. In Block J lectures, somatosensory, oftentimes we just call it sensory, okay? And then green text, that's going to be like for the other sensory stuff, or special sensory, if you will, like smell, vision, taste, hearing, vestibular sense for balance, stuff like that, okay? So let's get started. So the first nerve, cranial nerve 1, olfactory nerve. You can also call it the olfactory tract. They're synonymous. So this one, it's anatomy-wise, it's not really a cranial nerves. It's actually part of the CNS. The more technical term is olfactory tract, but you can call it olfactory nerve. It's fine. The anatomy, essentially, if you go in your nasal cavity, at the very top of that, you have your olfactory cells. Okay, those are like your first order sensory neurons, right? They smell the molecules, and they have axons that project through a part of your ethmoid bone that's called the cribriform plate. So this is like a part of the bone with a bunch of little holes. So the axons kind of go through the little holes, and they essentially reach the cranial cavity, where they synapse onto a region called the olfactory bulb. So you have a bunch of neurons there, and then these have axons that project to your brain, and those axons together bundled up, that's what we actually call the olfactory nerve, or olfactory tract, as I said earlier. And essentially the function for that is pretty straightforward. It's just for your smell. So the way you would examine it is that you would ask the patient to close their eyes. You would ask them to occlude one nostril, and you would essentially place a substance under the other nostril and ask them to identify it. So coffee grounds, spices are good things to use. Not something we test routinely, but if you have a suspicion for like a CN1 lesion, you would test for that. So when would you suspect that? Well, so what else to note? So these olfactory cell axons are very susceptible to head trauma, right? You have axons going through the cribriform plate. So you have like very, very thin fibers going through like little holes in bone. So you can imagine if you hit your head, you get shaken a little bit, it's very easy for these axons to essentially get cut. So that's one context in which you would suspect it. Frontal basal tumors, right? Tumors in that region, that's exactly where your olfactory nerve is going to be. So that's another situation in which you would suspect it. And patients will complain of obviously anosmia. They won't be able to smell as well. Something else to note is that they might also complain that they don't taste as well. So CN1 is not obviously not responsible for your actual taste innervation, for your taste buds. It's just that smell actually plays a role in the perceived taste that we actually perceive, right? What we call flavor. So that's why they might complain about this. Okay, so the second one, optic nerve. So the optic nerve, again, it's not really a cranial nerve. It's part of the CNS. It comes from the retina. The retina itself is actually a part of the brain. So it's an extension of the diencephalon specifically. So its anatomy. So essentially you have at the back of your retina, you have the retinal ganglion cells. Those have axons that essentially bundle up to form the optic nerve. It goes through the optic canal, and that's what we call the optic nerve. Once you reach the optic chiasm, there's going to be a partial decussation. So part of them are going to cross, and it's going to continue as the optic tract. So it's a continuation of the same axons, but we give it a different name. And that's going to go to your thalamus, to the LGN. And when I say partial decussation, what it means is that all the axons from the retinal ganglion cells on the temporal side of your retina, these axons are going to stay on the same side. And for the retinal ganglion cells on the nasal side, right, they're going to cross over to the other side. The function of that is for vision. And the way you would examine it, you can use a Snellen chart, right, for visual acuity. You can test visual fields. You can test pupillary light reflex, and also to look into the retina, do a fundoscopy exam. So what's important to note? So CN2 is the afferent arm of the pupillary light reflex. And also, when patients have increased ICP, so intracranial pressure, it's directly going to affect the optic nerve and the retina. And you can use the fundoscope to look into the eye, and you're going to see that as papilledema. And usually that's like a bilateral thing. So you're going to see it in both eyes. Okay, third nerve, the oculomotor nerve. So this one has two nuclei that you should note. The one is a somatic motor one, oculomotor nucleus. The other one is a autonomic nucleus, parasympathetic, Edinger-Westphal. And both of them are located in the midbrain, up top-ish at the level of the superior colliculus. And when it exits the brainstem, it's one single nerve, the oculomotor nerve, and this nerve passes through essentially a venous sinus called the cavernous sinus before exiting the skull via the superior orbital fissure. Now, the cavernous sinus has a lot of things that actually pass through it, and you should know what things go through the sinus. So I put it in parentheses here. It's 3, 4, V1, V2, 6, and the internal carotid artery. Superior orbital fissure has many of the same things going through it. This is 3, 4, V1, and 6, but it's not exactly the same content, so make sure you don't mix up the two. In terms of function, the oculomotor nucleus, it controls extraocular movements for most of your extraocular muscles. Essentially, the way to remember it is all the muscles except for the superior oblique and the lateral rectus, as well as the levator palpebrae superioris. That's for your upper eyelid elevation. As for your Edinger-Westphal nucleus, that's parasympathetic control for your pupil constriction and also for the accommodation of the lens. So essentially it allows the lens to thicken when you look at something near. Examination, so first you would just look at a patient, make sure you look for ptosis, misalignment of the eyes, look for mydriasis, which is to say like a blown pupil, and isochoria, so the pupils are not equal in size. You would also test, you do the H thing, right, to test for the extraocular movements. You do the pupillary light reflex, and also the accommodation reflex. The accommodation reflex, essentially, you ask them to look at your finger, you bring it close to their eyes, and as their eyes converge to look at the near object, their pupils should be constricting. And what else to note? Well, it's the efferent arm of the pupillary light reflex. Fourth nerve, trochlear nerve. So the trochlear nerve it's a very simple nerve, has one single nucleus. It's the trochlear nucleus. This one's in the midbrain at the level of the inferior colliculus, so it's a little lower than CN3. This nerve also passes through the cavernous sinus, and it exits the superior orbital fissure as well, same as CN3. The function, it's very simple. It controls a single muscle, one of the extraocular muscles, the superior oblique muscle, which does three things, which you should know: intorsion of the eyeball, depression, and also abduction. So in terms of examination, it's pretty similar to the three. I mean, 3, 4, 6, you essentially examine them together, where you look at the alignment of the eyes and you do the extraocular movements. A CN4 palsy can be a little subtle to see on exam. So when you guys get there in a clinic, like you can look it up. There's like more advanced techniques to actually see a CN4 palsy. What's important to note, so CN4 is a couple of interesting like trivia facts that often get quizzed on. So it's the only cranial nerve of the 12 that exits from the brainstem dorsally. Everything else exits either like ventrally or like laterally. This one comes out from the back of the brainstem. It's also the only cranial nerve that provides contralateral innervation. That is to say, like the left CN4 is going to innervate the right-sided superior oblique muscle, right? It's cranial nerves, every other one essentially provides ipsilateral innervation for the same side. This is the only one that does it crossed. The decussation of CN4 occurs within the brainstem. So by the time the nerve comes out of the brainstem, it's already crossed. Yeah, Sarah, it's abduction, not adduction. Okay, what else is, sorry, where was I? Yeah, so they're going to complain of diplopia. For CN4 palsy, what you might see on like the stem of the question is that this is someone who's going to complain of diplopia when looking down and in. Okay, so for example, if you're reading a book like this, or if you're looking downstairs as you're going downstairs, they might have diplopia. So that's something to look for in a question stem. Trigeminal nerve, CN5. So this one has a lot of nuclei. The only one that I think you're expected to know is the spinal trigeminal nucleus, also known as the spinal nucleus of 5, whatever it has a few different names. This is a long nucleus. It's mostly in the medulla. Part of it goes into the pons, part of it goes into the cervical spine, but in the most part, it's in the medulla. And the trigeminal ganglion, okay, this is akin to like the dorsal root ganglion, and this is a ganglion located in the periphery, so it's right outside of the brainstem. And essentially from there, CN5 has 3 branches. It has V1, V2, and V3, ophthalmic nerve, maxillary nerve, mandibular nerve. V1 and V2 pass through the cavernous sinus, V3 doesn't. And in terms of the exits, they all have different exits. V1 goes through the superior orbital fissure, V2 the foramen rotundum, and V3 the foramen ovale. And it has a lot of functions, but essentially really the key kind of term to remember is that it takes care of facial sensation. Roughly V1 corresponds to like your eyes and nose areas at the top of your face. V2 is like the middle of your face, your cheeks, your upper lip. V3 is like your lower lip, your jaw, and also like the anterior 2/3 of your tongue. And this is for sensation, like touch. V5 also, the CN5 also has like some motor function. I'm not going to talk about like the nucleus, which branch of it. All you need to know is that CN5 has a motor function. It controls the mastication muscles for chewing. The masseter, the temporalis, a couple of other ones. Don't need to know the names, just that it controls the mastication muscles. So in terms of examining it, obviously it's just facial sensation, where you just touch both sides of the face, see if they feel it. You can also test for the corneal reflex, which is like when you touch the cornea, not with your fingers, with like a piece of tissue, cotton or whatever, and you essentially elicit a blinking bilaterally. And you also can ask them to clench their jaw and to essentially palpate the tone of their mastication muscles. So over the cheeks for the masseter and over the temples for the temporalis muscles. So what else to note? This is the afferent arm of that corneal reflex I was just telling you guys about. And specifically it's V1, okay? The corneal reflex is for V1, V2 and V3 play no role in it. And when you have a CN5 lesion, what patients might complain about, of course, is just insane pain in the face. That's trigeminal neuralgia, also known as Zigdurur. It's one of the most painful conditions in medicine, so pretty clinically important. Okay, next one, very simple one, this one, abducens nerve. CN6, this one has one nucleus, the abducens nucleus. This one is in the pons. It passes through the cavernous sinus, goes through the superior orbital fissure, and the current theme is that when a nerve does that, it's going to your eye, right? So this one's going to your eye, and it's for one muscle, the lateral rectus, and that's for abduction of the eye. So it's for alignment. You can look for alignment of the eyes, test for extraocular movements. This one's pretty easy to test for and to find and to see. Patients are going to complain of horizontal diplopia. The other thing to note is that the sixth nerve it's particularly long and thin. So it exits the brainstem and actually travels quite a bit of distance before exiting the skull. So essentially what that means is that it's actually very prone to compression. And within the brain itself, if you have like an increased intracranial pressure for whatever reason, this is a nerve that easily gets compressed and essentially becomes dysfunctional, even if there's not a lesion like in the pons itself. And this is called a false localizing sign. When you have like, let's say like a tumor like up top in your brain, but then you have a manifestation like a CN6 palsy, but there's actually nothing in the brainstem. So essentially localization is misleading. That's what a false localizing sign is. Okay, so facial nerve, a little more complicated, has a lot of nuclei, covers a bit of every type of function. The most important one, of course, is the facial motor nucleus. So if you remember a single thing, this is the one you should remember. It also has the superior salivatory nucleus, the spinal trigeminal nucleus, and the nucleus of the salivatory tract. These nuclei are essentially in the lower pons and across the medulla. So what you should know is that the facial nerve, the facial motor nucleus, the axons, before they exit the brainstem, they actually make a little loop. I put the image here. They make a little loop around the abducens nucleus, and that creates a little bump at the back of the pons. And this is what we refer to as the facial colliculus. And the seventh nerve, along with the eighth nerve, they exit together. They exit through the internal auditory meatus. So in terms of function, again, the most important thing to note here is that the facial motor nucleus takes care of your facial muscles. So all of your facial muscles is 7, except your mastication muscles, that's 5. Okay, that's what you should know. The other stuff, it's extra. It's not super high yield. I just put it there for sake of completion. You can look at it if you want to, but it has a lot of functions and has many nuclei. I guess the only thing that's worth pointing out is that the nucleus of the solitary tract for the seventh nerve takes care of taste innervation in your anterior 2/3 of the tongue. So when it comes to the anterior 2/3 of the tongue, pure somatosensation, that's 5, right? And taste, that's 7, okay? So just make sure you don't mix up the two. When you examine it, you can just examine the facial movements, make them, smile and puff up their cheeks and raise their and furrow their like wrinkle their foreheads, like shut their eyes real strong, and also like web up their neck, right? That's for the platysmus. So that's the 5 facial movements and the corneal reflex. So blinking is 7th nerve, right? So that's the efferent arm of the corneal reflex. The other thing that's really, really important to note is like the whole forehead sparing concept when it comes to facial weakness, right? So if you have facial weakness, it's very important to know, is there facial sparing or does it involve the forehead as well? And the idea is that the lower motor neurons of cranial nerve 7 that actually take care of the forehead receive bilateral upper motor neuron innervation. What that means is, of course, that if you have like a stroke, like an upper motor neuron lesion, there's going to be forehead sparing, right? But if you have like a nerve lesion, if you have a Bell's palsy, then the forehead would also be involved. 8th nerve, vestibulocochlear nerve. So this one has a couple of nuclei. Essentially, you have the vestibular nuclei and the cochlear nuclei. And these are in the pons and the medulla, mostly in the pons. The 8th nerve exits the skull along with the 7th nerve through the internal auditory meatus. So pretty straightforward. Cochlear nuclei, that's for hearing. Vestibular nuclei, that's for vestibular sensation, right? But that's for like balance. So, I mean, the way you would examine for it, for hearing, it's pretty straightforward. You just rub your fingers next to their ears, see if it's the same on both sides. You can also try to distinguish between conductive and sensory neural hearing loss. I don't think you guys have covered that just yet. You're gonna have like specific lectures for that later in the block, and you're gonna learn about the tests, like the Weber test and the Rene test, to distinguish between these two. All you should know for now is that if you have a CN8 lesion, the type of hearing loss you have is sensory neural. Okay. The other thing to examine is the vestibular sensation. So obviously, if you have a vestibular sensation impairment, these people are going to have vertigo. They're going to feel like the room is spinning around them. So you have tests for that. You're going to have a lecture about that later on in the block. I'm not going to talk about that now. But something very simple is that when you're examining the patient's eyes, when you're doing like the 3, 4, 6 exam, also look for abnormal eye movements, look for nystagmus. Those things can be indicative of a CN8 lesion as well. So what else to note? Apart from hearing loss and vertigo, they might also complain of tinnitus. So that's like when you hear ringing in your ears. And lastly, essentially this nerve, it's particularly vulnerable to compression from tumors in a location called the cerebellopontine angle. So just remember this term, it might show up on the exam. So tumors there, you might have like a meningioma in that region. Acoustic neuromas, also known as schwannomas, also often appear in that location as well. Okay, 9 and 10 are a little complicated. After that, it gets easy. Okay, so bear with me. So for the ninth nerve, the glossopharyngeal nerve, this one also has 4 nuclei, kind of like the facial nerve, right? Like 4 nuclei covering like each of the 4 types of functions, right? So you have the nucleus ambiguous, which essentially innervates a single muscle, the stylopharyngeus muscle, the inferior salivary nucleus, the spinal trigeminal nucleus, and the nucleus of the solitary tract. They're all located in the medulla, and the nerve exits through the jugular foramen. The jugular foramen is the cranial exit for 9, 10, and 11 together. They exit together. So in terms of the function, again, this is more than what you need to know. If you retain one thing, I think the most important thing is that it uses the spinal trigeminal nucleus for sensation of the pharynx and larynx. This is really huge, okay? Also, I think what's interesting to note is that the ninth nerve takes care of the posterior third of the tongue. And it takes care of both the somatosensation and also the taste sensation for the posterior third, but it uses 2 separate nuclei to do that. And that's all on the slides. The question, should we know all these nuclei? So no, again, you don't need to know all these nuclei. This is probably a little more than what you need to know. This is all from the slides. So technically, I guess it's fair game, but if you don't have the time and like you really want to focus on the high yield stuff, I would only focus on what I've highlighted here, right? So essentially for the 7th nerve, I would focus on the facial muscles, right? That it's facial muscles, the motor aspect of the facial nerve. And for the 9th nerve, I would focus on the sensation for the pharynx and larynx. So that's what I would focus on. So the way you would examine the 9th nerve, okay, oops, Frank, I'm not sure what super important factor you're referring to. I think I've mentioned a couple, so I'm not. I think it's the sensation of the pharynx and larynx. I think that's the one I was referring to. So that's it. Okay. So examination, you would do the gag reflex. Unfortunately, the 9th nerve is a tough nerve to examine. Gag reflex is one of the only things you can do, really. So it's the afferent arm of the gag reflex because, again, right, it takes care of the sensation for your pharynx and your larynx. The other thing to note is that you can have a condition called glossopharyngeal neuralgia. This is similar to trigeminal neuralgia, but it's rarer. The triggering factors are a little different, but it's a similar kind of pain. Okay, the 10th nerve is a pretty important one. This one has, again, right, you're starting to see the pattern, 4 nuclei covering each of the 4 types of functions. So these nuclei are all in the medulla. And again, the 10th nerve exits the skull along with 9 and 11, right, through the jugular foramen. And you guys, I'm sure, remember the recurrent laryngeal nerve, right, the one that, you know, kind of goes through, like down to the aortic arch, loops back, right, takes care of like your phonation. And if you mess that up during like surgery, you get like hoarse voice for the rest of your life. Not great. So this comes up from the vagus. So in terms of function, I think there are 2 main, like really important things to note. The first one is nucleus ambiguous. So this one, the vagus nerve takes care of most of your muscles in your pharynx and your larynx. This is the main thing to note, okay? And essentially, like swallowing, speech, the vagus nerve is going to be very important. If we go back a slide, you see that the glossopharyngeal also does like one muscle, the stylopharyngeus, so it kind of plays a role in it as well, but it's really mostly the 10th, so associated with the 10th nerve. And the second important thing to note is the dorsal motor nucleus. That's the parasympathetic nucleus for the vagus nerve. And this one essentially, that's like the 2 vagus nerves that go down like your heart and like takes care of the parasympathetic output to your viscera, to like your heart, your lungs, your GI tract. So that's huge. This is a really, really important thing to know. So that's it, okay? Note that the vagus nerve also takes care of a bit of the sensation in the pharynx and larynx, but again, this is mostly the 9th, okay? So sensation of the pharynx associated to the 9th, motor stuff, like muscles in your throat, associated with the vagus. How would you examine it? The gag reflex, of course, because this is the efferent arm of the gag reflex. You can also just listen for dysphonia, listen for dysarthria. Dysphonia is hoarseness, right? So it's a phonation problem. Dysarthria is an articulation problem. So you're slurring your speech. And you can also ask them just open wide and just say ah, and you look for the uvula if it's kind of like elevating symmetrically. if there's a 10th nerve lesion, right, you're going to have an asymmetrical palatal elevation, and the uvula is going to deviate, right, because one side is going to raise higher than the other. What you should remember is that the uvula is going to deviate away from the side of the lesion. So if I have a left-sided CN10 lesion, then my left palate isn't going to elevate, right? So my right palate is going to elevate, and that's going to like tilt the uvula towards the right, away from the left-sided lesion. Okay, so it's away from the lesion. And the autonomic symptoms require bilateral CN10 lesions. So what I mean by that is if you need to have both sides messed up if you want to have parasympathetic impairment, okay? Because one side can take care of the entire body. Okay, 11 and 12, it's going to be a breeze. Okay, it's much easier. So spinal accessory nerve, the 11th one. This is not really a cranial nerve, it's a nerve. But really it arises from the C1 to C4 spinal nerve root, so it's not really like cranial. But the reason why we call it a cranial nerve is because when a nerve comes out of the spinal cord, it's actually going to go into your skull. It's going to go up through the foramen magnum into your skull, and then it's going to exit the skull again, along with 9 and 10 through the jugular foramen. The nucleus of the spinal accessory nucleus, this is located in the spinal cord, essentially in the anterior horn, right, which is a part of the spinal cord that actually does motor stuff, right? Essentially, it extends from C1 to C5, so it's cervical spine. And essentially, it innervates two muscles, this nerve, right? The sternocleidomastoid, this is the one in your neck that makes you turn your head, right? It makes your head turn to the contralateral side. So if I have my left SCM contracting, my head is rotating to the right side, okay? And the trapezius for like shoulder elevation. So you would examine it exactly this way. You would ask him to rotate against your head, against your hand. You would ask him to elevate your shoulders. What you should know is that the head rotation, the sternocleidomastoid, this is only innervated by CN11. The trapezius is innervated by CN11 and also a couple of other things. So essentially the specific test for CN11 is the sternocleidomastoid function. And what else you should note is that the spinal accessory nucleus is the most caudal of the cranial nerve nuclei. It's the most like, it's the lower down because it's in the spinal cord. It's not even in the brain anymore. Lastly, the hypoglossal nerve, CN12. So this one very simple. A single nucleus, the hypoglossal nucleus, located in the medulla, very medially. It exits the skull via the hypoglossal canal. Doesn't share it with anyone else. And the function for that is simple, right? It innervates the ipsilateral half of your tongue muscles, makes your tongue come out. So the way you would examine it is that you would ask them to stick out their tongue, and you would look for like muscle atrophy, for fasciculations, essentially like lower motor neuron findings. And you will also look for tongue deviation. So if you have a CN12 lesion, you would have a tongue deviation to the same side of the lesion. So if like my right-sided CN12 is messed up, my tongue, when I stick it out, it's going to deviate towards the right side, to the same side of the lesion. This is important to know. You can also just push your fingers up against their cheeks and have them essentially push back against your fingers through their cheek with their tongue and see how strong their tongue is. That's another way to examine it. So in terms of what you should note, patients might also complain of like speech and swallowing difficulties. As you can imagine, tongue function is important for those. And lastly, hypoglossal nucleus, it's very, very medial in the medulla. Like in the medulla, dorsal medulla, like hypoglossal nucleus is like the most medial nucleus. So you should know this. So a couple of random facts to end this part of the review. So cranial nerve neurons involved in motor function obviously are all lower motor neuron stuff, right? They're the lower motor neurons, so you would look for lower motor neuron findings. This one I said already, but all the autonomic function from cranial nerves are parasympathetic. There's no sympathetic cranial nerve stuff. You can also note that all the cranial nerves with like a sensory function, like a somatosensory function, they all use the spinal trigeminal nucleus. So spinal trigeminal nucleus receives plays a role for cranial nerves 5, 7, 9, and 10. With the exception of cranial nerve 4, all the unilateral cranial nerve lesions cause ipsilateral dysfunction. Again, remember, it's right. The fourth nerve is the only one that crosses. That's it. I would also say, like, if you have time, go back to the Block J stuff and make sure you understand the concept of like direct and consensual responses for the cranial nerve reflexes. So the pupillary light reflex, the corneal reflex, and the gag reflex. And I didn't cover too much of like visualization. I don't think it's too important for the exam, but like it's a good idea to go back to lecture slides and just quickly go through the slides, make sure you have a general sense of where the different nuclei are in the brainstem and you can visualize the brainstem. Okay, that's it from me, guys. So I'm gonna stop sharing my screen and hand it over to Tasnia.
All right, can you hear me? So I'm going to be starting with the spinal cord and peripheral nervous system. And I sort of put these two together because some of the pathologies we'll get into will overlap. So it's sort of easy to look at them simultaneously. So we'll start mostly centrally and move outwards as we go through this particular part of the lecture. So one of the most important things, and I think it's especially for the spinal cord and the peripheral nervous system, is really the anatomy. Knowing the basic spinal cord anatomy with like a cross section is absolutely critical to really understanding the pathologies that can occur with spinal cord involvement. This particular diagram has like a number of different tracts. There are only 3 that are really important for Block J, I would say, and I've sort of pointed them out with asterisks. We have the dorsal white columns that include the fasciculus gracilis as well as the fasciculus cuneatus, which is important for ascending information of vibration and proprioception. We have the lateral spinothalamic tracts, which are important for carrying pain and temperature information. And then we have the lateral and ventral corticospinal tracts, essentially the corticospinal tracts, which are a descending tract that carry motor information from the brain. So we'll go through the tracts a little more carefully now. We'll start with the dorsal white columns. So like I mentioned, this is an ascending tract. Sensory information comes in from the peripheral receptors and goes through the dorsal root ganglion and ascends via these dorsal white columns ipsilaterally. So the information regarding vibration and proprioception stays on the same side of the spinal cord as the limb the information comes from, for example. On the other hand, this is in contrast to pain and temperature information, which comes in, for example, from the left arm through the left dorsal root ganglion, and then synapses onto second order sensory neurons in the gray matter of the spinal cord. These second order sensory neurons cross the midline and then continue to project on the contralateral side of the spinal cord in the lateral spinothalamic tract. So this is one of those like really basic and important things to understand, is that pain and temperature sensory information crosses over. And typically it can cross over at the same level, or it may ascend 1 or 2 spinal levels before synapsing onto these second order neurons. But just to note. And then the final important tract to really know about when talking about the spinal cord are the corticospinal tracts. So these are the tracts that are coming from the motor cortex and descending down into the spinal cord after pyramidal decussation. So these are coming from the contralateral side of the brain, in fact, and descend down and synapse onto the anterior horn cells, which then project through the ventral root and go on to innervate the muscles. And importantly, here in this particular diagram, we have the lateral corticospinal tract and the ventral corticospinal tract that's sort of separated out. They're essentially the same tract, but the lateral aspect of it innervates more so limbs, whereas the ventral aspect is more central. So things like the trunk and neck are innervated by the ventral corticospinal tract. Okay, and then if we look at blood supply, here I'm giving you a very simplified view of the blood supply in a cross-sectional sort of overview once again. But the important thing to really remember is that we have 2 posterior spinal arteries, as well as 1 anterior spinal artery that help vascularize the spinal cord. And importantly, because there's only 1 anterior spinal artery, it can be more prone to ischemia. And also this particular artery supplies a large portion of the spinal cord. In fact, the anterior 2/3 of the spinal cord are supplied by it, with the posterior spinal arteries mostly involved in dorsal column vascular supply. And so the final thing I want to talk about in relation to basic spinal cord anatomy is the monosynaptic reflex. If you have a good understanding of this, a lot of the clinical sort of pictures that will come up will make a lot of sense as well. And so the most simplest reflex that we can think of are these stretch reflexes that have been sort of talked about both in block J as well as block H, if I'm remembering correctly. So it's really important to know these, know the root levels for these stretch reflexes. Here I sort of have like a schematized version of the biceps reflex. So they have essentially two arcs. There's an afferent arc involving the information that's coming from the spindle fibers or detecting of stretch when you sort of use a reflex hammer on the biceps tendon. That's in like this purple color here. So that sensory information would be going up with the dorsal white columns in terms of like proprioception information. But these neurons also synapse onto the anterior horn cells, which are part of the efferent arc and the motor sort of output. And so when for example, the biceps tendon is stretched, you have this information going into the spinal cord and then synapsing on these anterior horn cells, which cause the contraction of the biceps muscle and the flexion of the arm. So, so that's the sort of like important anatomy to know in terms of the spinal cord. And of course, we've heard this on a number of different occasions, but knowing these like different neurological deficit patterns with both upper motor neuron lesions and lower motor neuron lesions are extremely helpful. So I would definitely advise you to either like remember this table or one of the ones Dr. Moore has given you, just because it's critical to localizing lesions. In both cases, both with central and peripheral lesions, we can have weakness. So both upper motor neuron lesions and lower motor neuron lesions, but it's the other sort of characteristics that can help differentiate these two. When we think of the spinal cord in particular, we're more so focused on upper motor neuron findings. However, as will become evident later, the anterior horn cell is essentially that's where the lower motor neurons start. So it's hard to look at purely anatomically because the anterior horn cells are sort of within the spinal cord. So continuing with the terminology of upper motor neuron and lower motor neuron lesion then. With upper motor neuron lesions, what you would have is no atrophy, no fasciculations in the muscle, but you would see an increase in the reflexes. You would also see a positive Babinski response or a plantar reflex with upgoing toes, as well as an increased tone, usually something refers to as spastic. Whereas with lower motor neuron lesions, yes, you have weakness, of course. You also have atrophy and fasciculations. The reflexes tend to be decreased, as well as having downgoing toes or no Babinski response. And tone also tends to be decreased or is described as flaccid. The last thing I'll mention here is sometimes with sort of an acute upper motor neuron lesion, reflexes and tone may be decreased. I'm just going to see, I think I have a question in the chat. So yes, what is the explanation for the upper motor neuron lesions not producing atrophy of muscles? Essentially what leads to atrophy of the muscles is the fact that they're not innervated anymore. So when there's an upper motor neuron lesion, there is still a lower motor neuron attached to the muscle. So in those cases, you don't see atrophy of that muscle. That's sort of like a very simplified view of it, but hopefully that helps answer the question. Okay. That's a good question, but the lower motor neuron doesn't necessarily need the upper motor neuron to continue to exist. So it wouldn't be getting innervation really, but it doesn't need it to continue to exist. Okay, so I'll move on to the next slide. Some of the high yield or things to look out for with deficits with spinal cord lesions are these upper motor neuron findings, like I mentioned. Another thing is cross-sensory findings, and I'm sure you can imagine why as we've gone through a bit of the sensory tracts that are in the spinal cord. Another really important thing is the presence of a sensory level. So the sensory level is defined as sort of the most caudal intact dermatome for both pinprick and light touch. And so it's below that level where you would no longer have normal sensation, so to speak, and that gives you a sensory level, and that's really indicative that you may have a lesion in the spinal cord. Bowel and bladder dysfunction is also something that can be quite common with spinal cord lesions. And the last thing is a description of Lermit's sign. So this is a paroxysmal neuropathic pain that reflects either demyelination or irritation of the nerves. And this is something that's usually elicited by neck flexion. So if there's a description of something like that, that would also be something that's indicative of a spinal cord lesion. If you understand the anatomy, the patterns of neurological deficits are much easier to understand. So I really urge you to really make sure you understand those tracts and where things tend to cross over. So now moving into some of like the patterns we see with spinal cord lesions, here are some incomplete lesions of the spinal cord. The first one being the central cord syndrome. This is a very common type of presentation with many different etiologies, a few of which I've highlighted here. The most common form is due to cervical hyperextension, so sort of a traumatic injury leading to hyperextension of the neck. Syringomyelia, as well as compressive lesions, can also lead to essential cord syndrome. And essentially the clinical pattern or presentation you see with such a thing involves bilateral weakness. And usually this affects the upper extremities more so than the lower, with a variable sensory loss below the level of the injury. In particular, with something like syringomyelia, which affects sort of the region more so around the syrinx, this can be limited to having just altered pain and temperature sensation at the particular level of the spinal cord where that lesion is, because that's where the axons would sort of cross over. A few other sort of patterns to recognize include the anterior cord syndrome. If you recall a few slides back when I was talking about the blood supply to the cord, you'll recall that the anterior spinal artery is important in vascularizing a large portion of the spinal cord. And if you have an occlusion that affects this particular artery, you can have bilateral weakness as well as an impairment of pain and temperature sensation because the corticospinal tract as well as the spinothalamic tracts are affected, whereas the dorsal columns are not, so you have sparing of vibration and proprioception. And while there isn't an image for it here, you can imagine a posterior cord syndrome where the exact opposite is the case, where both posterior spinal arteries are perhaps occluded. Other etiologies include trauma or multiple sclerosis. And here you would have bilateral loss of proprioception and vibration below the level of the lesion with a sparing of motor function as well as pain and temperature sensation. And finally, in terms of incomplete lesions in the spinal cord, you can have an hemicord lesion, also known as Brown-Séquard syndrome. The etiologies here include things like trauma as well as spinal cord compression, whether it be from like a malignant mass or an abscess or disc herniation, which we'll talk about in a few slides. And here, what's really important is you would have loss of proprioception in that particular side of the spinal cord, as well as a spastic paralysis below the level of the lesion because the corticospinal tracts and all of those descending tracts are also affected. So you would have sort of an upper motor neuron picture mostly, and you would also have a contralateral loss of pain and temperature sensation, because as we sort of saw just a few slides ago, those fibers tend to cross over. And so they would have, that information which would have already crossed over is from the other side of the lesion. The other important thing when thinking about spinal cord lesions is looking at spinal cord versus conus medullaris and cauda equina. a lot of the typical findings I mentioned apply mostly to the spinal cord. So you're expecting upper motor neuron signs below the level, a sensory loss below the level. You'll often have bladder dysfunction, and usually this is not associated with pain. With the conus medullaris, which is still part of the spinal cord, it's very similar. However, the conus medullaris doesn't actually have any significant limb innervation. So you might not see motor weakness that's very evident on a physical exam, for example. However, you would have sensory loss, and this would be a sensory loss of the sacral region. So sort of like perianal, for example, anesthesia. And this part of the spinal cord is also involved in bladder function. So you will most definitely have bladder dysfunction if there is a lesion here. And once again, it's not commonly associated with pain. On the other hand, when looking at the cauda equina, in terms of motor symptoms, you actually have more patchy lower motor neuron findings, as well as a patchy sensory loss. And this is sometimes associated with bladder dysfunction, depending on the particular nerves that are affected. And this is a more so painful syndrome. So having cauda equina being a part of the clinical picture is usually associated with much more pain. So some of the possibilities for these lesions include mechanical compression. In fact, these are some of the most common reasons for which we have these syndromes. And disc herniation can do this either centrally by affecting the cord or conus and involving much more upper motor neuron signs, or it can bulge more laterally, causing compression of the nerve root, in which case you would see more lower motor neuron signs. And disc herniation is something that we can see in younger people as well as older individuals, whereas something like central canal stenosis or foraminal stenosis is much more common in older individuals when they have osteophyte formation causing a narrowing and compression of the spinal cord subsequently. So here it's an image of how a herniated disc can sort of bulge out laterally and compress the spinal nerve, leading to more a peripheral nervous system picture rather than central. So now moving, as I mentioned, more peripherally, these are the sort of things you can look for peripheral nervous system lesions. Or that would point you towards that direction. Bilateral symptoms without a sensory level is often a good indication that you may be looking more peripherally for a lesion. Also, if you have length-dependent and symmetric sensory loss, for example, that could be another good indication that you need to look at the peripheral nervous system. And then, of course, if you have a specific nerve that seems to be affected, or if a specific root territory is affected versus an entire body region, like an arm with a stroke in the brain, then you're more likely thinking peripheral nervous system, as well as face-sparing lesions tend to be peripheral. I think Xiao mentioned earlier that the cranial nerves technically are part of the peripheral nervous system, but they tend to be shorter and are also much more protected. And so you don't see this type of disease affecting them as often, although it is possible. So with the peripheral nervous system, I think this is a table that Dr. Moore also provides in his lectures, but it's a good way to sort of organize how you look at the peripheral nervous system. So once again, if we start the most centrally, we can look at the anterior horn cells, which tend to have a radicular pattern of weakness, as they are part of the lower motor neuron. They are lower motor neurons, in fact. You would expect to see atrophy, fasciculations, hyporeflexia. And as a motor neuron, you wouldn't see sensory involvement with damage to the anterior horn cells in particular. Whereas with the nerve root, you would have, once again, a radicular pattern of weakness with atrophy, fasciculations, and hyperreflexia, as well as sensory involvement. Because if you remember sort of the cross-section of the spinal cord, the dorsal and ventral roots are quite close to each other. So oftentimes there's both motor and sensory findings. The plexus is sort of a combination of nerve roots as well as peripheral nerves. So the presentation can be quite complex with a mixed radicular and nerve pattern. But nonetheless, there are lower motor neurons in the plexus. So you would have, once again, atrophy, fasciculations, and hyperreflexia that you could expect to see, with some sensory involvement as well, with sensory neurons being affected. With the peripheral nerve, it would be a nerve pattern with atrophy, fasciculations, hyperreflexia, as well as sensory involvement usually. And then we move further peripherally with the neuromuscular junction. And here the characteristic is of fatigability. So something with good strength initially, for example, shoulder abduction, after repetitive motions may have decreased weakness there. So that's sort of an indication that you need to look at the neuromuscular junction perhaps. Here, you wouldn't have atrophy, fasciculations, or hyporeflexia as the lower motor neuron is not affected. In fact, it's just the junction. And you wouldn't have sensory involvement once again because it's the neuromuscular junction that's affected. And so the sensory neurons should be fine. Finally, with muscle involvement or myopathies, the patterns of weakness are usually much more proximal, affecting, for example, the shoulder girdle or the hip flexors. And here you can have atrophy because of direct injury to the muscle, but you wouldn't have fasciculations or hyperreflexia because the lower motor neurons, once again, are not affected. And similarly, if the muscle is affected, that doesn't really affect the sensation aspect of things. And so this slide is more so for your reference later on, but it goes without saying that if a pattern fits a particular dermatome or myotome, then it's much more likely to be an issue involving a root. So yeah, if you have, for example, C5 involvement, you would potentially expect a deficit with elbow flexion, a sensory deficit near the shoulder, as well as perhaps a decreased reflex of the biceps. And so just to end off here, I'm going to go through some selected peripheral pathologies with sort of patterns that can be useful to just sort of recognize for both multiple choice questions, but also in clinical practice later on as you move on into clerkship. The first one is ALS or Lou Gehrig's disease. And this can often present with lower motor neuron findings only initially, and that's because it primarily involves anterior horn cells, which are, as I mentioned, lower motor neurons. But as the disease continues to progress, you can have upper motor neuron findings as well. So this is a disease in which you would have solely motor findings of mixed lower and upper motor neuron type. Another important pathology to keep in mind is Guillain-Barré syndrome. This is sort of a group of different autoimmune conditions that can be either affecting the axon or demyelinating. It's not clear exactly how all of these come to be, so to speak, but there is some association with some Guillain-Barré syndrome types with previous Campylobacter infections. So if in the stem, for example, there's mention of diarrhea, GBS should be something that comes to mind. And the typical clinical presentation here is ascending paralysis with absent reflexes. Another thing to look for is proteins in the CSF, which can be used essentially to confirm the diagnosis. And you may hear or read about albuminocytologic dissociation because you have increase in the proteins in the CSF without having an increase in the number of cells. The other things I'll mention as well are diabetic polyneuropathy, mostly because this is just a really, really common presentation, and it's the most common stocking glove distribution neuropathy that you'll see. So once again, typically you'll have involvement primarily of the feet, but also the hands. And it's sort of a length-dependent neuropathy with decreased sensation, for example, at the fingertips compared to the wrist and more proximately. And it tends to affect more small fibers initially, and then as it progresses, larger fibers. So things like proprioception are only affected much later on, and initially pain and temperature findings are more effective. A few other peripheral pathologies going more peripherally once again include myasthenia gravis, which is a neuromuscular junction issue. The really characteristic thing here is the fatigability. You can sort of have transient symptoms of like ptosis, for example, with eyelid droopiness that isn't always present, but with, for example, upward gaze, that might be an issue as well. This is an autoimmune disease with antibodies against the acetylcholine receptors, and that's sort of what leads to the pathology. Botulism is another neuromuscular junction affecting pathology, but here the botulinum toxins actually result in disruption of presynaptic neurotransmitter release. So you would have a decreased release of acetylcholine in these cases. And I won't get into it further than that, but so that's another thing to look out for neuromuscular junction issues. And the final thing with myopathies is that there are a number of different etiologies for different myopathies, including inherited or genetic forms, inflammatory forms of myositis, so dermatomyositis, polymyositis, those types of things. There's also a number of toxic etiologies, including thyroid disease, but also different medication uses can induce myopathies, such as steroids or statins. And the important pattern here, of course, as I mentioned earlier, is the proximal muscles being more so affected than distal. And just a very, very quick word on EMG. It can be useful in detecting or sort of helping with precision of the localization. It can help detect whether something is demyelinating or not, or if there is subclinical involvement. But beyond that, I don't think you guys will be tested on EMG. I think Dr. Moore has made that pretty clear in previous years anyway. It's more so to know that it's a tool that can be used to help help specify the diagnosis of peripheral pathologies in particular. And I think that's it for me. I'm just going to double check whether the questions were all answered.
I think there was one question about why PNS lesions would present with bilateral symptoms.
Yes. So that is sort of alluding to pathologies like diabetic neuropathy, in fact, which affect like sort of a length dependent pattern. So here, the longest nerves essentially in your body are the ones that go down to your toes. And so in that pattern, you would have a symmetric loss of the most long axons, so things affecting touch and such. So that's why it would be symmetric in that case. I think I sort of got lost in my own words, but I hope that helped answer your question. All right, great. I think I will let Liam take over then. And if you guys have any questions, feel free to put them in the chat and try to answer them in between. I know it can go quick. All right, off to you.
Thanks, Tasnia. And I'm excusing myself to everyone in advance if there's any background noise because there was a power outage at my place. So I'm in a public location. So I'm going to be presenting movement disorders. So let's get into it. So essentially movement disorders, what we're denoting in this context is disorders of the basal nuclei or basal ganglia. So they're kind of, I tried to break it down into like diagnostic categories. So you have the Parkinsonian disorders and you have the hyperkinetic disorders. So within Parkinsonian disorders, you have Parkinson's disease and then the Parkinson's disease kind of confounders that we'll get into later on. And then in hyperkinetic disorders, you really think of chorea, but also like tremors, restless leg syndrome, dystonia, Tourette's syndrome. And then there's two kind of pathologic categories that you can break Parkinsonian disorders into that are actually kind of high yield to think about. So you have synucleinopathies where alpha-synuclein deposits in the central nervous system. And those are really Parkinson's disease, multiple system atrophy, and Lewy body dementia. And then tauopathies, you have tau protein deposition. So in the case of movement disorders, you have PSP and CBD, which we'll get into later on again. And I kind of front-loaded the information here. So it'll kind of get lighter as we go later on. But essentially, in terms of definitions, just of major things to kind of address. So first, a tremor is really defined as a rhythmic and oscillatory and involuntary movement. So that idea of rhythmic and involuntary is really essential to the definition of tremor. And the DDX, the differential of tremor, is going to depend on whether it's a resting tremor versus an action tremor. And when you think of resting tremors, really how you'll think about is Parkinsonisms, versus in action tremors, you're going to have, essential tremor, but also enhanced physiological tremor and dystonia, especially in the context of a head tremor. And then the other things around here are just kind of for your FYI. Then so the definition of bradykinesia is really slow movements with small amplitudes and decreased reaction time. So you can think, well, we'll get into it, but like things like micrographia, like small kind of writing, kind of shuffling gait. So that's the picture of bradykinesia. And chorea is kind of the opposite. It's brief, unpredictable, and irregular movements. And they can be partially suppressed, but they are involuntary. And the way that people usually suppress chorea is by masking using voluntary movements. And then there are tics, which are stereotyped, brief, and repetitive actions due to an inner urge, and they are actually suppressible. So to get into some clinical anatomy, so first, dopamine is going to be the major neurotransmitter of focus for movement disorders. And this is kind of a simplification of the system. Oh, I'm seeing that there are some, yeah, so Saman, yes, chorea is the hallmark of Huntington's disease. So I can't actually see the chat, so I can just address them kind of between sections. So yeah, dopamine is going to be our major neurotransmitter of focus. Movement disorders involve more than just dopamine, but really at this level, we're going to kind of simplify it to just understand dopamine, because I think that's really the essential part of movement disorders at this stage. So dopamine is produced in two main areas, in the substantia nigra, specifically the pars compacta part. But if you just remember substantia nigra, that's more than sufficient for now. So the substantia nigra neurons actually project, so they synapse onto neurons in the caudate and putamen, which is also called the dorsal striatum, okay? And so this kind of synapses onto higher order, well, through the thalamus and then onto higher order neurons, which lead to motor and cognitive regulation. So you can think of like the, basically the motor cortex and the frontal cortex. So when we talk about nigrostriatal pathways, we're really referring to dopaminergic pathways, right? Involving the substantia nigra and the dorsal striatum. So this is essentially like the main pathway that's relevant to movement disorders here. And then we have dopamine in the ventral tegmental area, which projects to the nucleus accumbens, also known as the ventral striatum. And this is more at the level of emotional and affective regulation via the limbic system. That's also very relevant in Parkinson's disease and in schizophrenia, of course. So the basal nuclei basically are nuclei that are relevant to kind of regulating and smoothing out movement. And when we say basal nuclei, we're really referring to the caudate, the putamen, and the substantia nigra. So really the nigrostriatal pathway. And these, so they're essentially like a loop that set the tone of movements. They take in information from the cortex, and they kind of filter out the wanted parts and eliminate the unwanted parts before sending it back through to the thalamus, and then all the way to the cortex. And so this is useful to know. You probably won't be tested directly on this, but essentially the pathway can be broken down, or the loop can be broken down into the direct pathway and the indirect pathway. The direct pathway essentially leads to activation of the thalamus and the cortex, and the indirect pathway essentially leads to inhibition of the thalamus. So I guess you can remember indirect equals inhibition. So this means that if you have too little dopamine, you have a decreased amount of movement overall, but also a dysfunctional filtering of movements. Whereas if you destroy the indirect pathway, you get an increased amount of movement overall and also dysfunctional filtering of movements. So too little dopamine would represent Parkinsonism, whereas destruction of the indirect pathway would represent chorea. So this is just kind of the anatomical correlation of what we just discussed. Not going to be on the Block J exam, but definitely will be on your anatomy exam. And then this is kind of what we'll get into in terms of the anatomic pathology of these diseases, particularly Parkinson's disease, which is what I'll talk about next, where you kind of lose dopamine-containing cells, notably in the substantia nigra, but as we'll see in other areas too. So the first disease within the Parkinsonian disorders section, and I'll just check if there are any questions here, okay, is Parkinson's disease. So this is the hallmark Parkinsonian disorder. And the definition of Parkinson's disease, like clinical Parkinson's disease, is really bradykinesia, so slow, small amplitude movements, and one other symptom, so rigidity or rest tremor. So remember that for Parkinson's disease, you need to have at least 2 motor symptoms to make the diagnosis, and one of them needs to be bradykinesia. That is really the key to Parkinson's disease diagnosis. However, the signs and symptoms of Parkinson's disease are more complicated than simply motor symptoms. Before you're going to have motor involvement and before you can make a clinical diagnosis of Parkinson's disease, you're going to have premotor symptoms like hyposmia, so difficulty smelling, constipation, REM sleep behavior disorder, or RBD, which is essentially not being paralyzed during REM sleep and therefore acting out your dreams. So like making a mess in your sheets, fighting your bed partner, running around while you're asleep, and anxiety or depression. Now, in terms of the motor symptoms, and this is particularly high yield, you can remember the acronym TRAP. So T for tremor, and remember that it is a resting tremor, and the classic tremor that they're gonna give you in STEMS is a pill rolling tremor. R is for rigidity. I is for akinesia or bradykinesia, but A works a bit better in this mnemonic. And P is for postural instability. And really the physical exam finding of postural instability is that you're going to stand behind someone and you gently pull them back by the shoulders and they'll take like many steps back. And of course you have to tell them that they can trust you and that you'll catch them if they fall. And then later on, you develop more non-motor symptoms like dementia and hallucinations, and this is really symptoms of advanced Parkinson's disease. So these cardinal motor symptoms that we've discussed, the TRAP symptoms, are due to a progressive loss of dopaminergic neurons, so neurons in the pars compacta of the substantia nigra, and eventually their terminals in the dorsal striatum, leading to an overall down-regulation of the thalamus and motor cortex activity. So you get that bradykinesia, that small, slow movement with like resting tremor, so unintentional movements. It's typically unilateral at onset, but then eventually it becomes bilateral. So you also have, as I mentioned, kind of alluded to earlier, involvement of noradrenergic, serotonergic, and cholinergic pathways, but really what we're going to focus on here is dopamine. And I think a really kind of useful thing that maybe isn't addressed so much in your Block J lectures, or it's kind of briefly touched on, is the BRAC staging. And that's like kind of an anatomical pathological way of describing Parkinson's disease progression. And I think like really the key to this is to understand that the kind of the alpha-synuclein ascends from the brainstem to the cortex as the disease progresses. And you're only going to get those motor symptoms once the alpha-synuclein reaches the substantia nigra, which represents stage 3 out of 4 of the BRAC stages. So before you get those motor that motor involvement, alpha-synuclein is already going to disrupt areas related to the vagus nerve, the olfactory bulb, and the locus ceruleus, and that's in like a kind of temporal, not temporal, but like chronological order. And then respectively, these things lead to the premotor symptoms of Parkinson's disease, like autonomic dysfunction. So, classically constipation, anosmia, and REM sleep disturbance, because the locus ceruleus is heavily implicated in REM sleep regulation. And then, so as I was saying, the clinical kind of motor Parkinson's disease represents kind of already pretty advanced alpha-synuclein kind of spread, right? So when you're at the motor stage of Parkinson's disease, you've already lost 70% of your at-risk neurons. Another really important point about Parkinson's disease is that this progression occurs over the classic, the classic teaching is 5 to 10 years, but really over decades, right? From the premotor, the early premotor, all the way to the, dementia and hallucinations kind of stage of the disease. So finally, for management, and really Parkinson's disease is probably the movement disorder that you're going to get the most information about in Block J. So I think that this is some management points are pretty important. So really the mainstay of treatment is replacing dopamine. And the way that we replace dopamine is actually with a precursor that gets converted to dopamine called levodopa, which is L-DOPA. And that's always given now with a DOPA decarboxylase inhibitor. DOPA decarboxylase is what converts L-DOPA to dopamine. And the reason that you give it with an inhibitor of that you give levodopa with a DOPA decarboxylase inhibitor is that it's going to decrease the peripheral kind of conversion to dopamine. So the reason that happened is that essentially historically, or previously it was levodopa alone that was given to replace dopamine, and people had a lot of side effects because they were getting dopamine kind of in the periphery. And the classic side effect was actually vomiting. So now we give levodopa carbidopa, which is also called Sinemet, and the origin of the word Sinemet is without emesis. So that's kind of how I remember the vomiting side effect of levodopa. So nowadays, the main side effect of levodopa carbidopa is dyskinesia. So if you give kind of too much dopamine, you kind of get like a motor accentuation, right? So you get that kind of dyskinesia. And that's going to be high yield for the other like management options. In early Parkinson's, you can give things like dopamine agonists, amantadine, and MAO inhibitors, specifically, kind of narrow spectrum MAO-B inhibitors. And this is really to kind of like, it just kind of softens the early symptoms. And then once you get into, like, once there's like kind of anxiety and depressive symptoms, you can give SSRIs to patients for symptomatic management. And then later on, I guess, once people are still responding to L-DOPA, but their tolerance is, their tolerance of the increasing doses is getting worse and worse, they could be surgical candidates. And essentially what's done is deep brain stimulation for Parkinson's disease, but only in those who are still responding to levodopa. So in terms of the other Parkinsonian disorders, essentially I'm going to go through each one kind of rapidly and just tell you like the red flags that you need to look out for in your clinical stems and eventually in your clinical rotations to kind of recognize that, okay, the person has bradykinesia, but it might not be classical Parkinson's disease. So the first one is multiple system atrophy. So the red flags for multiple system atrophy is very early autonomic dysfunction. So think of that constipation, like urinary symptoms, kind of digestive symptoms, and then cerebellar symptoms, right? So kind of, instead of like involuntary movements, kind of, uncoordinated movements. And then if you image these patients, you can see often cerebellar atrophy and changes in the pons. Next disorder is Lewy body dementia, and this is not really Parkinsonian per se. It's more in the like dementia category, but it's like you can think of Lewy body dementia as essentially dementia plus Parkinsonism, so dementia plus bradykinesia. And the red flags that you look out for Lewy body dementia is early cognitive symptoms and visual hallucinations. So basically dementia type symptoms. Next entity is progressive supranuclear palsy or PSP. the red flags of that are kind of early falls, early gait disorder. So think of the wheelchair sign in PSP. So this is the wheelchair sign is essentially when someone is coming in for a wheelchair, with a wheelchair, and it says on the consultation request, rule out Parkinson's disease, you think of PSP. In PSP, you also have early personality changes, and cognitive impairment, and eye movement abnormalities. And this is where, like, the way I remember eye movement abnormalities is with the supranuclear part of PSP. So it's really like supranuclear eye movement abnormalities. So difficulty with the intentional eye movements, like persecutory saccades. If you image these patients, you can see midbrain atrophy. Then you have finally cortical basal degeneration. So the red flags of cortical basal degeneration are really cortical things. So, well, notably like sensory disturbances. So really that's my trick for remembering, like, okay, cortical basal, you know, the cortical component, you're going to have sensory changes. And then you'll have like really like kind of bulbar changes. So like speech difficulties, but also dystonia, myoclonus, and apraxia, right? So like kind of these kind of jerky movements. Cortical basal degeneration also classically presents unilaterally. And if you image these patients, you can see unilateral cortical atrophy. So if you see a Parkinsonian patient with unilateral sensory changes, then you can think of cortical basal degeneration. And generally, there are other red flags that can just point you away from a Parkinson's disease diagnosis in someone presenting with bradykinesia. So this would be like an initial symmetrical presentation. And I know that this kind of contradicts the whole unilateral thing in cortical basal degeneration, but Parkinson's disease also initially presents unilaterally, and a rapid disease progression, which is to say in less than 5 years, as well as if you give them kind of, I don't want to say empiric, but you give a trial of levodopa and there's a poor response, then that kind of also points you away from Parkinson's disease. So I wanted to do a quick Korea drive-by. This is not really extensively addressed in the Block J lectures, but I think it's like good to see the kind of counterpart of Parkinsonian disorders. So remember that Korea is that brief, unpredictable, irregular movements, and they're always kind of unintentional. They can be partially suppressed by masking, but they can't be fully suppressed because there's no intentional component to them. And this Korea happens due to the suppression of the indirect nigrostriatal pathway, so leading to more activation of the thalamus and the cortex. So you kind of get a disinhibition of unwanted movements. And the main pathological entities, when you think of Korea, you can think of Huntington's disease, which is a trinucleotide repeat disorder. You can think of Sydenham chorea, which is in childhood due to group A strep infection. And then you can think of vascular disease. Classically, it'll be like a kind of stroke involving the subthalamic nucleus, but actually most parts of the basal ganglia if they're involved in a stroke, could lead to chorea. And then there's also chorea secondary to HIV, and that's actually the most common infectious cause of chorea. So I'm just seeing in the comments here that there are some questions. So in lecture, they highlighted that Parkinson's disease is not only a dopamine disease, but also related to synuclein protein, right? Does that impact treatment, or was it mainly new info that's not applied clinically yet? Then, yeah, Tasnia says, so that's a good answer from Tasnia. Yeah, so synuclein is kind of like, you can see it like alpha-synuclein is kind of like abnormal protein that's depositing within the brain. And it mainly deposits in neurons that produce dopamine. So it's synuclein, we know that it's involved in the pathogenesis of Parkinson's disease, and we know that dopamine is a big player in Parkinson's disease symptoms, like in causing the kind of presentation of Parkinson's disease. All right, cool. Okay, so next on to tremors. So there's kind of I don't think this is the highest yield for your exam, but I think distinguishing between essential versus enhanced physiologic tremor is very important, and also knowing the difference between these tremors and Parkinsonian tremors. So remember that Parkinsonian tremors are rest tremors, whereas essential and enhanced physiologic tremors are active tremors. Essential tremor is actually the second most common movement disorder after Parkinson's disease. And it's an action tremor, so meaning it's absent at rest. It's a tremor that's higher in frequency than the tremor of Parkinson's, so it's actually faster. And the kind of key historical clue to essential tremor is that it's actually suppressed by alcohol consumption, whereas you won't get that in physiologic tremor. And there's often a family history, but genetics of this is very complicated, I'm sure. So in terms of the enhanced physiologic tremor, it's also an action tremor. It's a confounder of essential tremor. And I think the key point of enhanced physiologic tremor is that everyone has a tremor. It's just usually suppressed. So when we're tired, or we have caffeine or other stimulants, or we have other diseases that kind of remove the physiologic suppression of our tremor, then our physiologic tremor comes out. And I just put a little reminder to the approach to tremors and differential diagnosis here. So really distinguishing resting, so a more Parkinsonian tremor versus an action tremor, like an enhanced physiological tremor or an essential tremor, as well as a dystonic tremor, especially if you see it in the head. So Shadi, I'm pretty sure that physiologic tremor is not responsive to alcohol, but I'm not the tremor expert. So if someone else can contradict me on that, I would welcome that. So finally, dystonia. So dystonia is defined as kind of a co-contraction of agonist and antagonist muscles. So it's essentially like muscle contraction that doesn't make sense. It's undirected. And dystonia, you can break it into focal versus segmental. So focal being kind of one muscle group involved, segmental being two kind of contiguous muscle groups involved, versus multifocal, meaning more than one muscle group involved, but they're not contiguous, versus generalized, meaning plenty of different, areas of the body involved. So the symptoms of dystonia are triggered by fatigue, they're triggered by stress, and they're triggered by emotions. So it's kind of similar to an enhanced physiological tremor in that way, actually. And they'll be relieved by rest, as well as specific sensory stimuli. And this is the classic geste antagonist that we talk about in dystonia. So the classic geste antagonist in cervical dystonia is people putting their hand on their chin to kind of stop the tremor of cervical dystonia. Cervical dystonia is also the most common focal dystonia, and the classic presentation of that, or kind of objective sign of cervical dystonia, is the no tremor. So people moving their head back and forth. The treatment is actually really cool to know. The first line treatment of dystonia is Botox injections to actually paralyze the muscles that are involved. And then there are other systemic treatments that I don't think are relevant for the Med 2 level. And now for Tourette's syndrome. So I think what's important to know about Tourette's is kind of the criteria. So to make a diagnosis of Tourette's syndrome, you need multiple motor tics, so at least 2 motor tics and at least 1 phonic tic, like a vocalization. And they need to be present for at least 1 year, or for a shorter period, but many times a day. And these tics must change over time in location, so different motor or phonic varieties, number, frequency, type, complexity, severity, etc. And Tourette's syndrome is generally seen as a disease of children. Its onset needs to be before age 21 to be considered Tourette's syndrome. The cutoff used to be age 18, but it's been kind of put forward. If someone presents with motor and phonic tics after age 21, it is not considered Tourette's syndrome. Exactly, it would be kind of treated differently. I'm not sure what it would be referred to if it's not Tourette's. That's a really good question. So just as a reminder, the definition of a tic is a stereotype, brief, repetitive action due to an inner urge, and it's suppressible. I think there are psychiatric diagnoses that also could involve things like this with presentation kind of later on in life, like after age 21, to kind of partially answer your question, Abby. So that's it for my section. I'm just gonna scan quickly to see if there are any other questions here. So Shadia, I'm pretty sure that it is essential tremor that is suppressed by alcohol. Okay, so I'll hand it off to Emilie if there are no other questions.
All right, so thanks, Liam. So hi, everybody. My name is Emilie. I'm in F3. Thank you all for being here today. I'll be covering loss of consciousness and talking a bit about seizures today. So just a reminder that anatomically, loss of consciousness implies dysfunction of both cerebral hemispheres or the reticular activating system, which is in the brainstem. And so as you saw in class, how we kind of think about the differential diagnosis of isolated loss of consciousness, it includes either syncope, so that could be orthostatic, so when standing up too quickly, neurally mediated, or it could also be cardiac, so caused by things like aortic stenosis or arrhythmias, or lastly, it could be caused by a seizure. Let me just see the chat. Perfect. So essentially when doing history taking, I like to think of it in 4 categories for loss of consciousness. So firstly, just the patient information, and then before the event, during the event, and after the event. It kind of helps me structure the questions I'm going to ask. So starting with patient information, firstly, you can ask about things like age, also past medical history. So, have they fainted in the past? Are they known for cardiovascular disease? You can also inquire about, their kind of development, like how the pregnancy went, if they reached their developmental milestones, if they are known for having had febrile convulsions from CNS infections, head trauma, seizures, things like that. And also kind of inquiring about family history for similar events. Also what medications they're on, and if there have been previous episodes of loss of consciousness, and kind of inquiring about those. So going into before the event, I've kind of labeled things depending on if it would be more indicative of a syncope, cardiac event, or a seizure. By the way, cardiac event is technically part of syncope, but we were taught to think of it as a separate category just because it's so important to detect. So firstly, starting with the setting before the event. So was the person, standing for a long time or stood up suddenly? Was there emotional stimulus involved? Was there hot weather? Was the person dehydrated? That would kind of all point more towards a syncope. If the person's on medication for epilepsy, for example, kind of discussing the medication adherence would, be something that would be relevant for a seizure. And then what was the patient doing at onset, right? So some provocating factors like head trauma or flashing lights would kind of point towards a seizure, whereas if someone was doing some physical activity, that would maybe be indicative of more of a cardiac cause. Finally, inquiring about the prodrome before the event. So let's say the patient kind of complained of feeling faint, sweating, some nausea, change in vision, like dimming in the vision, or the patient was worried they would lose consciousness. That could lean towards a syncope. If the patient kind of complained of palpitations and angina, and the loss of consciousness was very sudden without warning, that could lean more towards a cardiac event. And lastly, if there's signs of an aura like vocalization or visual symptoms, that could point to a seizure. So during the event, Firstly, it's important to just ask and look for falls or injuries that happen during the episode of loss of consciousness. Also inquiring for the duration of the episode. Syncope could last in the range of seconds, whereas a seizure could be like a minute. So that's important to ask. I put convulsions as, could be syncope or seizure because there are actually some convulsing syncopes that happen. So there is convulsion. So when you see convulsions, it could be a syncope or a seizure. So it's important to kind of take the rest of the history into context. And automatisms that would, point towards a seizure. If the eyes are opened, if there are eye movements, and if the person is stiff, that would once again point toward a seizure, whereas if the person is more limp, that could point towards a syncope. Then looking at the color of the person when the event happened, if they kind of turn blue or red, that could point towards a seizure, whereas if the person became very pale, that would be more indicative of syncope. And lastly, signs of incontinence, tongue biting, frothing, or hypersalivation are also more pointing towards a seizure. And lastly, asking about the level of consciousness is helpful also. Okay, so for after the event, this is a big one, is to kind of see if there's, signs of a post-ictal period, which is a big clue that this could be a seizure. And what I mean by a post-ictal period is a period after the event of loss of consciousness, where the person takes a long time to recover a consciousness and alertness. Other signs could be fatigue, sleepiness, headache, muscle soreness, focal weakness. So these are things that would make you think of a seizure. So now on to the types of seizures. Here's a picture of a classification of seizure types. So first you can see that we can talk about onset, so if it's focal, generalized, or unknown. And then for focal seizures, you can kind of determine if the person was aware or if there was impaired awareness. And then you go into the onset, so whether it was motor or non-motor. And finally, it could be a focal to bilateral tonic-clonic seizure. So just going in quickly on focal versus generalized seizures. So for focal seizures, as I mentioned, it could be with or without impaired awareness. And there are focal signs depending on the brain region that's involved. So those could be variable. Lastly, important, there could be an aura, which is like the onset of a focal seizure, where there are specific symptoms like olfactory symptoms, visual symptoms, sensation of déjà vu, things like that. And so for generalized seizures, you can have primary versus secondary. So primary is that the seizure is generalized originally, versus secondary is that the seizure starts focally and then spreads generally. And the two main types that you saw in class were tonic-clonic, also called Cranial, which kind of starts with a vocalization, and then a tonic phase, which is illustrated here on the right, and then a clonic phase, also illustrated here. Those usually have a longer duration and a prolonged post-ictal period, whereas an absent seizure, which is the other type that was discussed, which is also called a proximal seizure, is usually shorter, with no post-ictal period. Essentially, it's just kind of like staring blankly into space usually. Another point to mention is that there's also another element in the differential, and that is the psychogenic non-epileptic seizures. So patients at risk for these are females more than males, and patients with a history of psychiatric disorders. And clinically, usually there's forced eye closure, side-to-side head movements rather than movements just in one direction, pelvic thrusting, variable motor activity, preserved awareness, and a prolonged duration. And usually these patients don't injure themselves during the event, and there's no post-ictal period. So quickly going into provoked versus unprovoked seizures. So when we talk about a provoked seizure, we talk about a seizure that was caused by something that triggers seizures in everyone. So that could be something like fever, like acute head injury, CNS infection like meningitis, some medication, severe electrolyte imbalances, things like that. Whereas an unprovoked seizure is a seizure that is triggered by something that would trigger seizures only in susceptible patients. So let's say like epileptic patients, right? So things like sleep deprivation, hyperventilation, flashing lights, stress, dehydration, skipping meals, things like that, that wouldn't trigger seizures in everybody. So just going quickly into epilepsy. So the definition of epilepsy is 2 or more seizures and an ongoing risk of recurrence. And we can kind of classify them into epileptic syndromes based on whether they are localization related or generalized. If it's caused by factors that are genetic, structural, metabolic, or unknown. And finally, you can further define the types by things like age of onset, family history, your neurological exam, the seizure type, the EEG results, and imaging. And a key point is that the role of EEG is to confirm the localization of the seizures and to classify the epileptic syndrome. It is not to confirm the diagnosis of a seizure because seizures are a clinical diagnosis. So that's a key point to remember. And lastly, just some medications that you should know. So there are 4, so we'll go through them quickly. So starting with carbamazepine, this is for treating focal seizures, and the side effects are things like skin rash, hyponatremia, leukopenia, and hepatotoxicity. Next, we have valproic acid, which is to treat generalized seizures. And some side effects are tremor, weight gain, hair loss, and importantly, congenital malformations. So you wouldn't want to start this medication in women who are pregnant or expecting. Next, we have phenytoin, which is to treat both focal and generalized seizures. And some side effects are hypersensitivity reaction, ataxia, gingival hyperplasia, rash, and hepatotoxicity. And lastly, we have levetiracetam, which is also to treat both focal and generalized seizures. And some side effects are behavioral problems, drowsiness, fatigue, irritability, psychotic syndromes, and aggressive behavior. So that's it for me. I'll pass it on to Maude and I'll monitor the chat if there are any questions.
Okay, so hi everyone. My name is Maude. I'm Med 3, and today I'm going to talk about cerebral vasculature and strokes. So let's get started. Okay, so first of all, we need to establish what is a stroke. So a stroke is an interruption or a reduction of the blood supply to the brain. And when that happens, the brain cannot get the blood or the oxygen that it needs. So this leads to brain cell death. And there's different types of strokes, as we know. There's first of all, ischemic type of stroke. So ischemic in the sense that we'll see it later, but just a brief overview that ischemic is where there's really a blockage in the blood vessel that prevent the blood to go further, and that creates ischemia. There's also a hemorrhagic type of stroke. So when the person is bleeding from mostly an artery, but it can also be from a vein, then the patient is losing the blood that was supposed to go further on, and then the part of the brain that is missing the blood cannot get the oxygen that it needs. And there's also a venous type of stroke that we'll see later really briefly, and that it makes a little bit of the ischemic and hemorrhagic signs or symptoms. So we'll see it later. So the first thing that we need to establish is really the vasculature anatomy. So that's really important for your anatomy exam for sure, but it's also important to understand strokes. So I don't know if you guys can see my mouse, hopefully yes. but we'll start here at the base of the aortic arch, so from the aorta. Then we have here what we call the brachiocephalic trunk. So the brachiocephalic trunk will go to the subclavian artery, which I blocked here because it's not what we are interested the most. And then here we have the common carotid artery, and then here the internal carotid artery, okay? And the internal carotid artery is what is going to supply the circle of Willis that we see on our right. And here I put a little stars from where the internal carotid arteries arrive, and then they give rise to the middle cerebral artery and the anterior cerebral artery that we see here. So as we can see, we have other vessels that form the circle of Willis. We have the anterior communicating artery, which gives rise to the, which communicates between the two anterior cerebral arteries. We have here the posterior communicating artery, which will let the vessels do this circle with the posterior cerebral artery. And this is most of the blood vessels that will supply the cortical brain. And then when we go further down, we start to have the arteries that will supply the brainstem and the cerebellum. So we have the superior cerebral artery, those two here. Then we have the basilar artery that gives rise to the pontine arteries. And then here we have the anterior inferior cerebral artery that we can call ACA. And then the posterior inferior cerebral artery, which are here, were from the vertebral arteries. And what I wanted to say is that the vertebral arteries, if we rely on the sketch on the left, we can see that they are connected with the subclavian arteries here. So this big thing is all related. And in the middle here, we also have a connection which will prevent that the brain gets ischemia in the first place if one of the two internal carotid gets obstructed. We also have lacunar strokes that we'll talk about later on. So I just wanted to show you the anatomy of that. So here we have the middle cerebral artery, or the MCA as we call it. And here are those little small penetrating cerebral vessels that will supply mostly the subcortical areas. So here is really the vessels that are going to create the lacunar strokes that we're going to talk about later. Okay, so first topic is ischemic stroke. So as I mentioned earlier, the ischemic stroke is really when the blood flow to the brain is blocked either first by a thrombus. So what is a thrombus? I always get confused between a thrombus and an embolism. So I wrote the definition here. So a thrombus is a blood clot that is formed in the vessels and remain where it has formed, okay? So it blocks the blood flow after the thrombus, so the thrombus, or it may actually produce an embolism that we'll see afterwards. So what are the two most common cause of thrombus for a stroke? Is first atherothrombosis. So atherothrombosis is a thrombus that forms in an atherosclerotic plaque. So for those of you who don't remember what is an atherosclerotic plaque, is a plaque here, a buildup of like mostly cholesterol kind of material that creates a narrowing in the artery, and that creates a coagulable state that can promote the formation of a thrombus. There's also the lipohyalinosis formation, which is basically a plaque of lipid hyaline that comes from hypertension. And this is the pathophysiology for the lacunar strokes. Okay, so for lacunar strokes, it's really a lipid hyaline buildup that will cause the ischemic stroke. So that's it for thrombus. For embolism now, so embolism is really when there's a blood clot or anything really that travels from another region of the body to the brain to cause the blockage. So example of things that can create an embolism, we have atrial fibrillation. Atrial fibrillation, which will create a really coagulable state for that, and blood clots will form and go to the brain. We also have left atrial thrombus. We have, for example, rheumatoid mitral or aortic valve disease, where the basically an embolism from the rheumatic disease that will go into the brain. There's also bacterial endocarditis, etc. There's really a lot. And finally, the last thing that can create a blockage in the brain blood flow is really something we don't really see a lot. It's systemic hypoperfusion. So if, for example, you are in cardiac arrest, for sure you're not pumping a lot of blood. So the entire body have hypoperfusion, and that includes the brain. And so you'll have symptoms of ischemic strokes in that case, but that's really rare and not really high yield for your exam. And as we know, ischemic stroke is the most common type of stroke, so it's really important to understand it. So what are the risk factors for ischemic stroke? Basically, anything that can create the thrombus or the embolism that I talked about earlier. So we have hypertension, as I mentioned. We have known arteriosclerotic plaque. We also have dyslipidemia because it can lead to arteriosclerotic plaque. Diabetes and smoking will create endovascular damage that can lead to thrombus or embolism. And we have atrial fibrillation, as I talked about, which is a really important risk factor for ischemic stroke. And actually, there's also there's this score here that's called the CHATS-2 score that evaluate the risk of a patient to develop a stroke if they have atrial fibrillation. And basically, the risk factors that are mentioned is congestive heart failure, hypertension, age, over 75 years old, diabetes, and prior stroke. And if the patient gets more 1 point or more, then you should give them anticoagulant to prevent strokes. And something that's really important to remember is that if you don't remember what's the CHATS-2 score about, then remember that it's an acronym, okay? It's not like the name of a person or something. It's really an acronym. So C for congestive heart failure, H for hypertension, etc. And S2, because the S meaning stroke, but it's really prior stroke, TIA, or thromboembolism. So any thing that could be related to stroke, not only stroke, but the 2 is because it gives 2 points to the person. So that's it. So you really have to remember the name and you're basically set to remember it. So what are the symptoms of ischemic stroke? So it's really something like weakness, loss of sensation like numbness, difficulty speaking, so aphasia or dysarthria, or visual loss. And rarely there's loss of consciousness, headache, and abnormal movement. But really, the 4 main symptoms are the ones that I just mentioned, and they're the ones that are important to know at our level. And it's really never just a loss of memory by itself or a decreased concentration. So that's really important to know, because especially in clinical practice, the patient will come, and strokes is so common in the population. They will be like, I think I had a TIA, like a mini stroke, and they're like, okay, what were the symptoms? It's like, oh, I lost my memory, or I have decreased concentration. And really, those are not really symptoms of ischemic stroke, especially if they're by themselves. Now, vascular territories of stroke. So it's important to know where the stroke happened, if it happened. And really, what it's important to know at our level, it's really the vascular territories of the ACA, so the anterior cerebral artery, the MCA, and the PCA, posterior cerebral artery. So we can think of it either as the anatomy. So if you know your anatomy really well, you can say like, okay, the ACA goes there, and if I know my homunculus that we see on the left, then I know which part will be affected, or you can learn it by heart if you prefer that way. But basically, the ACA will mainly give blood to the medial surface of the brain. And as we can see in the homunculus, this is really the region for leg weakness. And so the leg will be the most affected part. Then we have the middle cerebral artery, which, if you refer to your anatomy again, really gives more rise to the lateral surface of the brain, where it's mostly the face, the arm with the hand, and proximal leg. And those are going to be the part affected by this kind of stroke. And then we have the PCA, so posterior cerebral artery, that obviously cover the posterior surface of the brain. And if we know our anatomy, again, we know that the occipital lobe is there. And so visual problems will usually happen with posterior cerebral artery strokes. Then we have the lacunar strokes that I keep talking about. So lacunar strokes are really the ischemic event happening on those little arteries that I talked about earlier. And those strokes, they are giving symptoms of face, arm, and leg. Okay, so the entire body. And the reason being that if we evaluate those, hopefully you see my mouse, but those arteries, they are like more deep into the brain, if we can say it like this. And so they cover motor neurons from this part of the brain, this part of the brain, and this part of the brain, really. So when they have an infarct, they really impact the entire motor neurons that are coming down. And that's why they have this effect on the face, the arm, and the leg. However, they usually spare language, spatial, and visual issues because those are cortical function, and so they won't get close to this area. And so really it's more of a weakness problem in those kind of strokes. Finally, we have brainstem strokes. I don't think you guys have seen it a lot. I think it's after the midterm that you guys usually see it, but we'll cover it very briefly. So basically, brainstem strokes, we can think about everything that can affect the brainstem, all the brainstem functions. If there's a stroke, then they won't function as well. So we have cranial nerves abnormalities, usually because the nucleus is in the brainstem. We have cerebellar dysfunction, for example, loss of coordination, because the brainstem and the cerebellum are usually connected, and no connections are being infarcted right now. And there's the motor and sensory problems. Again, they will spare language and visual functions because those are cortical functions and not brainstem function. So here on the right, I showed a little bit of the brainstem anatomy that we saw earlier. And this is where the stroke could happen if there's a brainstem stroke. Okay, so the management of an acute ischemic stroke now. So if you see a patient and you think that they have an ischemic stroke, the first thing to do is really to do a CT scan. So the importance here is really to confirm, is there really an ischemic stroke, or it could be an hemorrhagic stroke? Because obviously, if it's an ischemic stroke, what you're going to try to do is really break the cloth, and that will give the patient an anticoagulant condition. But if it was an hemorrhagic stroke, then the patient will bleed a lot more. So that's you don't want that. So you need a stat CT scan first. And we have to remember that an ischemic stroke is any type of stroke is an emergency. Time is brain, so you have to act fast. So the three things you can do for an ischemic stroke is first aspirin. Okay, it's not really used. It's really only used if IV TPA and thrombectomy, so the two other things that you can do, cannot be used for whatever reason. And so, but we don't usually do it because it's not as high yield for the patient, but it's an option if those two other options doesn't work. The thing that we use the most is IV TPA. So IV TPA, which is something that will dissolve the blood clot by, if we see on the right, by promoting the plasminogen to plasmin, to change into plasmin. Okay, so TPA will act here, changing plasminogen to plasmin, and plasmin will be able to break the fibrin clot into fibrin degradation products. Okay, so really, it's this thing is it says it in the name. TPA means tissue plasminogen activator. So really, it's a plasminogen activator that will be let the molecule basically to change into plasmin, which will in return just change a fibrin to fibrin degradation product. IV TPA is really helpful if you give it in the first 4.5 hours. So you really need to act fast. And usually it is preferred from thrombectomy because it's less invasive. Thrombectomy, finally, is the last thing you can do for an ischemic stroke. It's a surgical procedure that basically, my PowerPoint didn't work, but it's to physically remove the blood clot. Okay, so you really physically remove it, and it only works for a proximal vessel. So like middle cerebral arteries, it can if you have a middle cerebral artery stroke, you can use it. But if it's too deep in the vasculature anatomy, then you cannot use thrombectomy. And this can be used in the first 12 hours. That's the official guideline, but now there's more studies that shows that even after 24 hours, it could still be usable. So that's it for ischemic stroke. So I'm just going to briefly present a TIA. So TIA, means transient ischemic attack, and it's basically a ischemic stroke that lasts less than 24 hours. Usually they last 5 minutes to 1 hour. Okay, but they can last up to 24 hours. And we won't talk about it a lot because we don't have a lot of time, but basically, if for treatment of risk factors and prevent recurrence, you need to treat it as much as a stroke, okay? Because it still has been a weird, abnormal coagulable state that we don't want, and so you need to treat them like if they had a stroke. And so, and also a little addendum, we know that a stroke can also be asymptomatic when it occurs in an artery that don't supply a part of the brain that really have a important or obvious function, but it still could happen, and then you can see it on CT scan afterwards incidentally. So I'm just gonna maybe look at the chat to see if there was a question. It's weird, I cannot open the chat. Okay, well, I'll look at it at the end. I don't know why I can't open the chat. But so yeah, so we'll go, if that's okay, you guys, or if you guys have a question, you can tell. Okay. Oh, I found the chat. Okay, there's no question. Great. Okay. So now let's talk about hemorrhagic stroke. So hemorrhagic strokes, they happen when an artery, mostly, but sometimes the vein, bursts and blood accumulates in the brain. Okay. So there's different type of hemorrhagic stroke. There's epidural strokes, which happen when there's blood between the skull and the dura. There's subdural stroke when that happens between the dura and the arachnoid. There's subarachnoid hemorrhagic stroke, which happens between arachnoid and the pia mater. And then there's intraparenchymal hemorrhagic strokes, which happen intracerebrally, so within the brain. And on the right, I put a picture of Dr. Moore's slides from last year. Hopefully he had the same slides for this year, because I found it very useful to really see your anatomy and where the hemorrhagic stroke is happening. So you have skull, epidural, dura, subdural, arachnoid, subarachnoid, and pia and intraparenchymal. And those are the places where the hemorrhagic stroke can happen. So we'll go into them a little bit deeper. So first we have the epidural hemorrhage. So epidural hemorrhage are really an emergency because they usually are from a artery, the middle meningeal artery, which is located between, like in the dura and in the skull, basically. So they can really, if you have a trauma there around this place, you can really have a basically the middle meningeal artery burst and create rapid accumulation of brain. So it is an emergency. And what we need to remember is that the dura is attached to at different points to the skull. And because of that, the epidural hemorrhage will only accumulate in between those two attachments. And that creates an important increased pressure in the brain, which is one of the reasons why it is such an emergency. And also, it gives the CT scan classic appearance of lens appearance. So basically, as we can see here, it's really like convex, I guess, or really like gives like a lens. It really looks like a lens, and that is the classic image of a CT scan of an epidural hemorrhage. Then we have the subdural hemorrhage, which is less of an emergency than epidural hemorrhage, since first of all, it usually comes from venous blood. So there is less rapid accumulation in the brain, so less increased pressure rapidly, which can lead to, as we know, the very big problems. And because also the blood can spread between the I wrote skull and dura, it's not right, dura and sub and arachnoid matter and arachnoid whatever this place. I have a blank right now. I will change it for you guys if you take the PowerPoint afterwards. And so because of that, because it can spread, it creates a less increased pressure less rapidly, and so the brain is less at risk for herniation or damage. And so on the CT scan, usually it gives like this a crescent appearance. Okay, so it looks like crescent of a moon, basically, because first of all, the blood is able to spread, but it also has been compromised between the dura and the subarachnoid. Then we have the subarachnoid hemorrhage. The cause of subarachnoid hemorrhage can be traumatic, idiopathic, but most of all, it can be from an aneurysm, okay? And we won't have time to go into details about the aneurysm, but I know in my year, Dr. Morse went into it. So I encourage you guys to look at it for all the implication. But basically, also the symptoms of subarachnoid hemorrhage, there's two types. There's first the worst headache of my life. If the patient says there's the worst headache of my life, it was sudden, it was severe onset, then you have to think about a subarachnoid hemorrhage. And if also there was loss of consciousness plus seizure, this is another type of subarachnoid hemorrhage when there was a complete tear of the aneurysm, which creates a really toxic effect in the brain from the blood itself, from the blood product. And that creates loss of consciousness, seizure, coma, and you really have to think about subarachnoid hemorrhage in that case. The treatment for subarachnoid hemorrhage, there's two. There's first of all the surgical clip, where we go in and put the clip that we see here. So a little clip that will basically clip the aneurysm and stop it from bleeding. And then we also have, there's also endovascular coiling. So we'll go into your artery, we'll go and put this coiling, which will promote clotting and stop the aneurysm from bleeding. And the preferred method is usually endovascular coiling because it's less invasive, is done as endovascular procedures with imaging and just go through an artery. And so it's really preferred if it's possible for the patient. Then we have intraparenchymal hemorrhage, which is basically a bleed in the brain itself. And the causes are multiple. Two that are really important is chronic hypertension. And so just a little side note on this, hypertension can either lead to lacunar infarcts in the pathophysiologic way that we saw, or they can also lead to hemorrhage, hypertensive hemorrhage intraparenchymally. And another cause of intraparenchymal hemorrhage is cerebral amyloid angioplasty. So that creates hemorrhage in a way that we don't need to know at our level, but just remember it. And symptoms of intraparenchymal hemorrhage are really similar to ischemic stroke, but they're more sudden, more severe, and they may not respect the vascular anatomy because obviously the hemorrhage just spreads around where they have space, and they don't need to respect all the vascular anatomy. And so why is important to recognize hemorrhage is because of all the consequences from increased intracranial pressure and herniation. So as we know, if there's blood in the brain, then for sure it's like an add-on from already all the space that all the things that there is in the skull, and the skull cannot move. So if you have more things in something that cannot change volume, then pressure is increased. And if you have increased pressure, then it will lead to direct damage to the brain. It can lead to herniation, and it can lead to decreased cerebral perfusion furthermore. So if you're bleeding, then for sure your cerebral perfusion of blood is already low. But then if you have more space, more things in your like fixed amount of volume, then they will the pressure will close the arteries even more. Put pressure on it so they will close, and that will lead to even less cerebral perfusion. So it's like a cycle that's never ending and not good. And what's herniation? So herniation is really important. It's when there's something that is added in the brain, like blood, but it can be other things like tumor, etc. The brain is gonna have to be pushed to try to like resist from the pressure. And usually there's a sequence of it of how the brain is moving, and this is what something that we really want to avoid. So the first thing that the brain usually do is really to do a subfalcine herniation. So it will move to one side of the other, or the other under the falx cerebri. And then afterwards, it will do a central herniation. So the brain will move down usually. And then we'll have an uncal herniation, where the brain is going to do this, as we can see in the image. And finally, there's a tonsillar herniation, which is really not good, where the brain is really moving. Sorry, I don't know why it keeps doing that. Moving down, and that is really catastrophic, and we really want to avoid that. So finally, we'll have cerebral venous sinus thrombosis. So this is the venous type of stroke that we talked about earlier. This is really rare, but we're gonna just have one slide on it. And basically, cerebral venous sinus thrombosis is when there's basically a blockage in the venous outflow. So that do a backup of blood before the blockage, which obviously will lead to increased intracranial pressure from the same mechanism as blood, the add-on blood that was in the brain. Because if there's increased blood flow in the back of the brain, there's going to be just more blood basically in the circulation, and that will increase the amount of things that is in the skull. And so really, cerebral venous sinus thrombosis gives symptoms of ischemic stroke, because obviously it's from a blockage, so it's kind of like ischemic, but also from hemorrhagic stroke, because the backup will create hemorrhaging most of the time. And so there's really like a mixed pattern here. The symptoms are usually headache, papilledema, so swelling of the optic nerve due to increased intracranial pressure, and usually bilateral symptoms of ischemic and hemorrhagic stroke. So this is a really big difference between the other type of strokes. We usually give one type or the other depending of what artery has or vein has the problem. But here we can have bilateral symptoms. And I said, please review the virtual triad for risk factor of venous stroke, just because we're already past time. And just there's the triad of things that gives risk factors for this kind of stroke. So that's it for me. I'll stop the share and try to look if there's something in the chat. I don't think there is. So good. Then I think that's it for everyone. And I don't know if any of you guys have like questions from anything we said before, really from the entire thing. Well, thank you guys for being here. I see a lot of thank you in the chat. Thank you for being here and staying. And hopefully you guys will ace the exam. I'm really confident for you.